Hi, this is Tom Charlton, and this is the 2022 protocol update for the rural EMS agencies that use these protocols. As always, no disclosures. So only a few protocols were updated, and none of them were really significant updates. We updated the administrative protocol, added in a pediatric and adult choking protocol, cardiac arrest, hypotension and shock, narrow complex tachycardia with pulse, hyperthermia and heat-related emergencies, pregnancy complications, specifically cardiac arrest, and then pediatric anaphylaxis. So during the administrative protocol update, determination was made that we're still having issues across the region with notifying receiving hospitals of certain time-sensitive diagnoses. As a result, it's mandatory that you alert for a STEMI, stroke, cardiac arrest, or post-cardiac arrest, ROSC, and then trauma. It's extremely important that you use the phrase alert. This is the same phrase that the hospital will use internally, and it should get attention so that the person receiving the phone call actually knows what to do with the information. The cardiac arrest protocol was also updated. Really, the biggest update to this was some change in the ventilation rate in kids. The protocol currently allows for a slower respiratory rate as currently exists, or we're adding in the option of one breath every 2 to 3 seconds, which equates to 20 to 30 breaths per minute. This is based on one study that was performed in pediatric patients that were already hospitalized and in an intensive care unit setting. In this one trial, it showed that the children that had faster ventilatory rates during their cardiac arrest resuscitation had better neurologic outcomes and had more ROSC. One of the issues, though, is that this trial was done on already very sick children that were already hospitalized and were already at the point of obtaining significant resuscitation. That is a significantly different child than we experience in EMS. There was much debate among us EMS physicians in the region about what best to do with this. Cincinnati Children's is adopting the PALS recommendation, which is one breath every 2 to 3 seconds during the resuscitation. However, the remainder of us did not feel that the evidence was overwhelming enough to justify this significant change. The issue is the faster you breathe for someone, the more intrathoracic pressure you're going to be producing, which inhibits venous return, which may then impact actual circulation. As a result, we're compromising by meeting in the middle. So you can continue to do your normal practice, or you can go to one breath every 2 to 3 seconds during the resuscitation. Additionally, on all patients, there's some evidence now that IV access may be superior to intraosseous access. So the preference is that you get an IV over an IO when able. However, as everyone knows, interrupting CPR is bad. So if to get the IV started, you have to interrupt CPR, that is bad, and you should start an IO instead, which hopefully will not require stopping compressions. Shock was also updated. Frankly, this was just an oversight by all of us in the region. Push-dose epinephrine is restricted to patients ages 16 or older. Cincinnati Children's is currently working on coming up with the dosing algorithm to be used on smaller children, which I expect will be published at some point in 2022, therefore making it into the 2023 protocols. Narrow complex tachycardia with a pulse that is stable. Essentially what this means is patients that are in SVT or AFib, rapid ventricular response, etc. If the pulse is at all irregular, it's important to consult medical control prior to antiarrhythmic treatment. This may indicate that the patient is actually in atrial fibrillation or atrial flutter with a rapid ventricular response and not actually SVT. As a result, we would not necessarily recommend performing the Valsalva maneuver or administering adenosine. For those that are in a narrow complex tachycardia that is regular with a pulse, consider augmenting your standard Valsalva maneuver with a passive leg raise. We're going to watch a video here shortly that goes over the study that this came from, but it has significant improvement in return to normal sinus tachycardia or normal sinus rhythm following this added passive leg raise. If after performing this augmented Valsalva, the patient is still rapid, you want to then administer adenosine if the tachycardia persists and is still thought to be a narrow complex tachycardia. It's still the standard 6 milligrams, 12 milligrams, 12 milligrams. I'm also going to show you an excerpt from another video that I performed on how to best administer adenosine.
I'm Andy Applebaum. I'm the Chief Investigator for the REVERT study. I'm also a consultant at the Royal Devon and Exeter Hospital in the southwest of England. Hello there. Hi. I see from your heart tracing that you've got a condition called SVT. Is that the REVERT trial was a randomised controlled trial to look at a method of modifying the Valsalva manoeuvre for the treatment of SVT. Asked you just to get a good seal around that with your mouth and blow hard enough to make the needle reach the target. Modification was designed to increase venous return during the relaxation phase of the manoeuvre and involved laying the patient flat and lifting their legs in the air at the end of the strain phase.
Okay, well done.
Overall, we found that patients that were randomised to the standard manoeuvre, only 17% of patients were cardioverted to sinus rhythm, whereas for the modified technique, 43% of patients returned to sinus rhythm.
You're doing really well. Good stuff.
It really does demonstrate marked improvement with the modified technique. And I think we should consider using that as a standard approach to the initial treatment of this condition. 5, 4, 3, 2, 1, and just completely relax. Lift your legs up in the air. So we used a blood pressure manometer that was modified for the trial, and that can be done in emergency departments, but in other practice or usual practice, a 10 ml syringe blown just hard enough to start moving the plunger, we believe gives a similar sort of pressure. Right. So you ready? Mm-hmm. And ready, steady, blow. And the benefit of that is that patients can use this at home and outside of the hospital because it's a condition that can recur. And that gives the patient some control and may mean that patients don't need to come to hospital in the first place. Okay, and we'll sit you back up now. Okay, you feeling okay?
Yeah.
It looks like from the monitor that you've gone back to a normal rhythm. So we're just going to repeat your heart tracing and go from there.
Lovely.
Okay, great. Thanks, guys.
So myth number 4, in order to get an adequate adenosine bolus concentration to the heart, providers must rapidly complete a complex series of actions. Large bore proximal IV site, 3-way stopcock, rapid flush pressure bag, IV fluids, raise the arm, whatever your various method of getting the adenosine in quickly is going to be.
You know what, Don? You do that rain dance. If it makes you feel better, that's terrific.
What if we all do the rain dance?
Great idea, buddy.
This is great. Now we can really bring on the rain.
So that's kind of how myths like this get started, is somebody has success with it and it's, oh my God, the success must have been because of the weird intricate thing that I just did. Therefore, we should always do that weird intricate thing, hoping to get the same result. So the facts. Adenosine does have a very short half-life in the blood. The cells, your red blood cells actually rapidly will take up the adenosine, and so less of it will be then available to be used by the heart. So when we get an inadequate concentration, once it gets to the heart, it's not going to have that desired effect. So we always, in emergency medicine, love the flashy procedure that has lots of fancy things. You know, we love the sexiness of a chest tube or an EJ or an IO, especially the IO, because we get to use a power tool when we're doing the sexy procedure. But we probably don't necessarily need to do this with adenosine. So if we do a high pressure injection, we can get some retrograde filling of the vessel. So we're injecting so fast that the vessel essentially upstream begins to fill up with adenosine as well, which means that the med goes the wrong way and it takes longer to get to the heart. Rapid injection is going to cause a highly turbulent flow, And so when we get turbulence, that's when we get better mixing. That's why when we stir a drink, it mixes up a little bit better. So that decreases the concentration available when it hits the heart. And then if you use a stopcock and a high-speed flush behind the med, it's further going to disrupt that bolus effect, because we're, again, providing turbulence into that vein that's going to mix it now with saline. Okay. So this is adenosine with pinched tubing. Okay. So if you saw that, what he did was rapidly injected while the tube was pinched and then let go of the tubing. Okay. So much faster than if we do the traditional method. Okay. So this high-speed injection doesn't appear to result in significant retrograde flow. The saline behind the bolus doesn't seem to really disrupt the med that is ahead of it. So this is an adenosine with an open line, okay? So just to watch it again, it's an open line to begin with, and then he does the injection without clamping, and you see that little bit of retrograde flow that occurs. But you still see some dilution from it. Okay. So rapid injection into low port of a rapidly flowing IV line seems to deliver the medication bolus most efficiently, without any significant mixing of the separation of the bolus. So that's what I've started doing now, is I've stopped using the stopcock. I've stopped using this rapid flush, etc. What I will do instead is have one of the techs or the nurses holding the bag basically as high as they can, or having it on a pressure bag. And so what I'll do is we'll pinch it off, put the adenosine into the line, and then as soon as the adenosine is into the line, release the clamp and get the flow of the saline happening again. Okay. So this is a stopcock when you use the stopcock method. So you see, you kind of get that two bolus effect with that. So that's not ideal either. So you see how that occurs. You kind of get this two bolus effect with it. So it really does separate that bolus out into these two parts, which really isn't beneficial either, because that's probably arguably going to dilute the concentration down even more and be less likely that enough of it is there at any given time to cause the desired effect at the heart. So this myth of needing to do this complicated weird dance to be able to get adenosine in, that really is busted. So the take-home message is, don't do these weird, complicated things when you're going to give adenosine. It's much easier to just simply do a nice controlled push into the low port of a rapidly flowing IV line that was kinked and then released. Okay, and you're going to get the best bolus of that actually reaching the heart, and it's a lot simpler. You don't have to time everything and get all sweaty because somebody isn't going to push it fast enough, etc. So do a nice controlled procedure instead. Adult and pediatric choking was added. Frankly, this was an oversight on my part. I did not realize until I was going through and updating the protocol that we technically didn't have a choking protocol. Essentially, what it boils down to is what we've always been doing. If the Heimlich is successful, we still want to encourage transport for evaluation. The reason for this is that there may have been aspiration or there may be partial blockage of the airway still, and so those warrant evaluation. It's important if the patient has arrested to visually inspect the upper airway prior to delivering all breaths in case the foreign body has been dislodged. This means simply just looking in their mouth. I do not want people routinely getting out a laryngoscope and McGill's forceps in between compressions to try and evaluate someone's airway. In the patient that has arrested as a result of their choking, consider early transport as surgical airway may be indicated. Hyperthermia and heat-related emergencies has had some updates added to it as well. One thing that I wanted to point out is that there is a significant difference between somebody who is hot and somebody who is hot with altered mental status. Someone who is hot and has altered mental status, meaning they're confused, they're not acting right, they may not be able to move appropriately, they may even be combative, that person is in heat stroke. Patients that are in heat stroke benefit from cooling, meaning an ice bath, a swimming pool, high flow cold water dousing like a garden hose. And it's important that this is done in a timely manner. There are some products out on the market right now that allow for essentially sideline cooling. You may see this with your sports medicine teams in the area. I am going to show you all a short video on how one of these devices is applied. That way you're more familiar with it. It's important that we cool the patient prior to transport if there's no other emergency intervention needed, meaning they have an airway compromise, they're actively seizing, or something else that additional intervention is needed. These devices you obviously cannot transport with because they're going to be carrying roughly 600 pounds of water. And while you're en route, you don't have any means of draining that water either. So the majority of the time, these are going to be carried out on the sideline or on the field where it was originally applied. The important thing to point out is that we are not trying to get this person back to a normal temperature. We are trying to get them cooler. Someone who gets back to a normal temperature is likely, even after we remove the immersion cooling from them, going to continue to cool from evaporation and radiant heat loss. We don't want this person to necessarily get hypothermic, which has happened in the region after one of these episodes. Try and get the patient to have improved mental status and get their temperature down into the 102 degree range. We're really only going for a few degrees of cooling, since typically these patients will be, 105 degrees or more in my experience.
The Polar Life Pod is a collapsible portable immersion system and the only device on the market specifically designed to facilitate quickly immersing an athlete in cold water on demand whenever and wherever needed. The Polar Life Pod is made out of heavy-duty PVC and is capable of fitting athletes up to 7 feet tall and weighing up to 400 pounds. The pod is packaged ready for use in a convenient carrying case, allowing for easy storage and quick availability. A full-length two-way zipper allows the athlete easy access into and out of the pod without requiring the athlete to be lifted. The Polar Life Pod comes with a floating head support that fits snugly inside the hood and helps reduce the danger of the athlete's head slipping underwater, along with the athlete being in a supine position, which helps keep the airway clear. The pod includes a port for the insertion of a thermometer to monitor the athlete's body temperature. The pod is held open to allow rapid filling with ice water from on-site containers. The Polar Pod minimizes water usage by using adjustable straps. The pod's hood with drawstrings and waterproof zipper allows for full body and partial head coverage of the athlete while minimizing water leakage. The water in the pod can be evacuated quickly at the foot of the pod, a safe distance from the athlete's head. While this video was running, the pod was set up and the athlete totally submerged. Seconds matter. To order the Polar Life Pod, call Polar Products at 1-800-763-8423 for a list of distributors. Visit polarlifepod.com or call for more information.
Pregnancy complications, specifically cardiac arrest. Really what this boils down to is that we want patients that are in cardiac arrest that are greater than 24 weeks gestation to be transported to the nearest emergency department for a possible perimortem C-section. The management of cardiac arrest in pregnant patients is extremely similar to the non-pregnant patient. You still use the same drugs, the same airway equipment. The Lucas device can be used if the patient can fit. While the person is undergoing chest compressions, attempt to move the uterus to the left of the abdomen, hopefully then taking pressure off of the inferior vena cava and improving venous return to the heart. If the patient needs an advanced airway, we want you to attempt supraglottic airway device preferentially because even a slight amount of hypoxia can cause significant risk to the patient and fetus. Pregnant females also tend to have a more swollen airway and may make the intubation attempt more difficult. Lastly, pediatric anaphylaxis. Really no significant change with this one. However, there is a new product that's on the market. Previously, there was no auto-injector that was available for infants and small toddlers to be able to have their parents administer epinephrine for. This new product called the AUVI-Q goes all the way down to 0.1 milligrams. It's similar to an AED where when you pull the cap off, it actually will start talking to you, similar to an AED. The protocol now authorizes all levels to administer this small dose epinephrine via the auto-injector if it's available on scene. We're not going to be carrying this in the field. This likely is going to be something that is prescribed from Cincinnati Children's, since it's about $700 per device, and also has a very limited window in which kids are the appropriate size for it. Otherwise, for patients that are greater than 10 kilograms but less than 25 kilograms, the standard EpiPen Junior or 0.15 milligrams is appropriate. And then essentially anyone over 25 kilograms or 50 pounds or so, the 0.3 milligram epinephrine auto-injector or EpiPen is the appropriate dose. Obviously, if you have any questions, please feel free to reach out to me, tcharlton@emsdoctors.com. I'd also like to ask that you go and visit emsdoctors.com, which is my new website. On it, you'll find a copy of these protocols in addition to additional training materials. The training videos that are up likely have a quiz that's been developed for them. Reach out to your training officer for a copy of that quiz. You watch the video, turn in the quiz, and then your agency may be able to issue continuing education credits as a result. Again, stay safe out there, and we'll see you next year.